address, and that we'll take up first because Dr. Mohammed MADY has to go to another hall, and it's on management of ruptured posterior capsule during phaco. So please welcome Dr. MADY.
First of all,
why don't you come to the front rows, please, so good interaction can take place. Why don't you come, can you all come to the front rows so that we can do a good interaction?
Thank you very much, Mr. President, for inviting me for this nice meeting. Okay. Okay, I would like to present here is that phaco nightmare, which is with ruptured posterior capsule during phaco, which is a very bad complication that can be met for everyone. But what I'm trying to do is how to escape going into this bad complication. Capsule problems and vitreous loss are inevitable. Even the best surgeon could have it. And so the challenge in cataract surgery is to minimize the risk of complication and optimally manage complications that do occur. In order to do that and to prevent this complication, you have to be ready before starting any case and early recognize the complication, respond early, and then go to the actual management as you planned. In order, if you have a big list of these complicated cases, you should be ready before starting such cases. Because every case, you should prepare a mental flow chart and maneuvers and sequence of decision before entering the patient eye in such a cases. Because each eye needs some sort of mental flow chart to how to deal with it. I will prepare surgeon, anticipate potential problem cases, and keep the required instruments on standby. Of course, prevention is very important, and we should realize that each step of cataract surgery is built on a solid foundation of prior maneuvers, early recognition. The index of suspicion of the surgeon should be very high in order to detect the bouncing of the iris diaphragm or changing in the anterior chamber depth or changing in the pupil size, or which might indicate break in the posterior capsule. Also, there's a reliable sign of vitreous is present if there is loss of flowability of the material and phaco efficiency during phaco or irrigation aspiration, because vitreous cannot be phacoed. It can only be cut. Early recognition is very important. Ominous sign of impending loss of material into the posterior segment is deepening of the anterior chamber and rotation of the nucleus. In the earliest response that we have, we should control our innate withdrawal response and on recognition of the problem, and go to foot pedal position 0, and don't remove anything from inside the eye, and inject viscoelastic, ideally dispersive, between the posterior capsule and the remaining lens fragment till the anterior chamber is normal depth. Then remove the phaco tip and go. Now, while you are relaxed, it's time to assess the situation, inspect, relax, and think what are you going to do, and announce the situation for the staff in the OT room, and the vitrector machine should be seamlessly ready in the room. This is a kind of vitrectomy kit that should be available in every room in order not to lose time while the eye is opened. And the actual management plan will start later on with augmentation of anesthesia if you need, damage control, compartmentalization of the anterior segment, manage the prolapsed vitreous with vitrectomy, remove the remaining nucleus, and manage the posterior dislocated or dropped nucleus or lens fragment, as you can see. Here I'm going to show a few cases. The first case would do while doing phaco. I am finished with this case. I noted superiorly here that I went deeper a little bit, so that I suspect they injured the posterior capsule superiorly by some glow is shining here, as you could see here, and will appear later on. I put in my mind that something wrong happened. That's why I decreased the fluidics and did nuclear disassembly in situ. I removed the nucleus. Then after removal of the nuclear material, I reassess the case for the place of the suspected tear, as you could see here, which will be more apparent, in order not to enlarge it and to keep the vitreous posteriorly as much as we can. Then while doing irrigation aspiration and cortical cleanup, I should start cleaning up the cortex away from the area of suspected tear or the presence of the tear. Then I always refill with viscoelastic, as you could see here, and here is the tear is apparent here superiorly. It is not enlarging yet, and I'm keeping the vitreous posteriorly. No vitreous prolapse happened yet. Then I use the white bore cannula, the one of the viscoelastic, the methyl cellulose, in order to do dry aspiration without introduction of vitrectomy here. Then I injected the lens in the bag without any vitrectomy. The next case is, I noticed a BCRent, one of the junior staff was doing surgery, as you could see here, that the eye is tilted and the visualization is not that much good. Something happened with him, posterior capsule ruptured, and one of the lens fragments displaced in the anterior vitreous. I had been called, then I went, then I refilled the eye with viscoelastic, removed the remaining cortical material, and the compartmentalizing the anterior segment, not to allow for vitreous prolapse, keep everything as it is without enlarging the posterior hole. Then, while injecting the viscoelastic, I should inject it inside the fornices of the lens, away from the hole, to tamponade the vitreous. Then I injected the single piece lens in the bag, just landed on the capsular bag without rotation, as you can see here. Then, after inserting the lens without that much dialing, I went with the irrigation aspiration, removed the remaining cortex. Then I went with the vitrector behind the lens and removed this displaced fragment, as you could see here. Here is the vitrector. Then I went to this displaced fragment and removed it, and the case is finished. The other case is during phaco here. Always, if I'm suspecting that the pupil is not that much dilating and the capsular texture is not that good, or failure of good hydrodissection, I always suspect that something is happening, and I keep the fluidics as slow as I can. Then I did nuclear disassembly in situ here without nuclear rotation. Then the epinucleus and the cortex were sticky, and the cortex was not hydrodissected. I always use the handpiece to remove the cortex and the epinucleus, and also I removed this sticky epinucleus, but I was just that arrogant enough to injure the posterior capsule myself, so it is a man-made mistake here. In order to remove this sticky material of the epinucleus, the posterior capsule ruptured here. Then I start to do vitrectomy. There's two basic things in the anterior vitrectomy. If you want to cut the vitreous, you have to use the cut aspirate mode. And in order to remove the remaining epinucleus or cortex, you have to use aspirate cut mode in the vitrectomy machine, as I'm doing here. Cut aspirate to clear out the vitreous. Then I convert it to aspirate cut in order to engage the epinucleus and not to allow it to fall posteriorly. Then I removed it completely and inserted, as you could see here, very slowly without allowing it to go back. Then when it's finished, I inserted the multi-piece foldable IOL. without. And the last case, I think I have to present this one, if you could allow me. Rupture posterior capsule before nuclear removal was managed with anterior levitation. Here, there's failure of good hydrodissection. Nuclear rotation was not good. While I'm doing trenching, there was difficulty in separation of the heminuclei. And while I'm trying to aspirate to engage the nucleus, I noted that anterior venous prolapse happened. This means that there's a big posterior rupture happened here. Here I kept the anterior chamber stable. I injected viscoelastic behind the lens material and elevated it anteriorly, and I used the cannula tab as a lever just to levitate it anteriorly. Then I removed it with the phaco here till the case is completed. And I always use viscoelastic during this maneuver in order to tamponade the vitreous posteriorly. And when I finished with the removal of the nuclear material and the cortex, I did anterior vitrectomy, then explored how is the integrity of the anterior capsule in order to prepare the eye for insertion of the lens. Here is the last piece of the nuclear material, removed with the phaco. Then I injected triamcinolone, anterior vitrectomy, then exploring the lens, anterior capsule with the Coughlin hook to be sure that only the posterior capsule is damaged. So there was no single piece or 3 pieces there. I inserted hard IOL on the capsular bag anteriorly. And thank you very much for your kind attention.